good evening everyone. Today we will continue with our presentation on the chest x-ray and what to look for. This will be the fifth and the last part, and we will see what we will do later. We have a few topics in mind. Okay, so last time we were talking about the mediastinum and we reached this slide in which we are talking about pneumomediastinum. First of all, keep in mind that pneumomediastinum, it's different from pneumopericardium. Okay, pneumomediastinum, it's not the same as pneumopericardium. They are different from each other. Pneumomediastinum is defined as the presence of extraluminal gas, which is most likely air, within the mediastinum. So it's the presence of air within the mediastinum. What are the causes of pneumomediastinum? We have multiple causes. The commonest causes are either blunt chest trauma or secondary to chest, neck, or retroperitoneal surgery, because retroperitoneally the gas or air can track up into the mediastinum. One of the commonest and the most serious causes of pneumomediastinum is esophageal perforation, which might be due to Borheff syndrome or endoscopic intervention. For example, if the patient has achalasia and they are trying for endoscopic dilatation of the esophagus might rupture and cause pneumomediastinum. Also, esophageal carcinoma can be a cause of pneumomediastinum if it perforates and cause problem to the cause leak of air. Okay. Now, regarding pneumomediastinum on chest x-ray, what does it look like, or what is the appearances of pneumomediastinum on chest x-ray? First of all, we will see air around the pulmonary artery, which will produce a black ring appearance. There will be a black circle around the pulmonary artery, and at the same time air around the arteries arising from the aortic arch, okay, will appear as black rings and often referred to as ring around the artery sign. There will be some black ring around the pulmonary artery and the major arteries of the aortic arch. Something in pediatric age group, in younger patients, there will be what's called angel wing sign, which is the normal thymus surrounded by mediastinal air. So the thymus will be obvious more than usual due to the surrounding air. These slides will demonstrate the difference between what we call pneumomediastinum and what is pneumoperitoneum. Pneumomediastinum, there will be continuous, there will be a continuous lucency outlining the base of the heart. You can see this is the base of the heart, and the diaphragm is continuous. We don't see that normally. Normally the diaphragm it fuses with the heart at the center, and this is called continuous diaphragm sign, and it indicates pneumomediastinum. Okay, while due to the air in the mediastinum that tracks extrapleurally, it's outside the pleura, between the heart and the diaphragm. Regarding pneumopericardium, it is air within the pericardial sac, not the mediastinum. That will result in the visualization of the parietal pericardium. It has two layers, you know, the visceral layer and the parietal layer. The parietal layer will be visualized, the pneumopericardium, and will show air surrounding the heart, but not necessarily a continuous diaphragm sign, because there will be no extrapleural air. It's air within the pericardium. So, although clinically not that much significant, pneumomediastinum from pneumopericardium, but radiologically there is a difference between what we call pneumomediastinum and pneumopericardium. Now, regarding the diaphragm, what are the main abnormalities that we can look for and detect on a chest x-ray? First, there is elevation of the diaphragm. Elevation of the diaphragm can be either unilateral or bilateral. So, what are the causes of unilaterally elevated diaphragm or hemidiaphragm? There are causes above the diaphragm, at the diaphragm, and below the diaphragm. Above the diaphragm includes phrenic nerve palsy, which can be due to infiltration from bronchial carcinoma or mediastinal tumor, since the phrenic nerve innervates the diaphragm. If it is infiltrated or lacerated in a surgery, for example, the phrenic nerve will be injured. That side, the diaphragm will not be working properly. Causes of unilateral elevated hemidiaphragm that are within the diaphragm itself, it's either eventration, which is more common on the left side. Eventration is more common on the left side, and it's due to the deficiency or atrophy of the muscle, leaving only a continuous layer of fibrous tissue, resulting in eventration. Causes below the diaphragm, in cases of the right side, the right diaphragm elevated due to liver or subphrenic abscess. Also, liver secondary deposits will cause elevated right hemidiaphragm. These are the most common cause. Also, some causes on the left side, the left hemidiaphragm might include some tumors, for example, gastric carcinoma or any mass below the left hemidiaphragm. So, what are the causes of bilaterally elevated diaphragm? Both the right and the left both of them are elevated. The most common cause by far is obesity. Okay, it causes elevation of the diaphragm bilaterally, both hemidiaphragms. Also hepatosplenomegaly, ascites, pregnancy, and abdominal masses. So in general, an enlargement below the diaphragm, either obesity or enlarged liver and spleen, distended abdomen due to fluid or pregnancy or a mass. Any distension below the diaphragm will cause bilaterally elevated hemidiaphragm. Rarely might be due to bilateral phrenic nerve palsy, but this is not common. Usually it's unilateral abnormality. Okay. What do we mean by diaphragmatic hernia? Diaphragmatic hernia, it is congenital defect in the diaphragm. It's more common on the left side. This defect, there is a hole, there is an opening in the hemidiaphragm that will allow the bowel to protrude from the abdomen through the defect into the thoracic cavity. Bowel will pass through a defect through the diaphragm into the thoracic cavity. For example, it can be hiatus hernia, in which part of the stomach will pass through the esophageal opening of the diaphragm. Also can be Bugdalic or Morgagni hernia, and we have to know what's the difference between the Bugdalic and the Morgagni hernia. So till now everything is okay. Do you understand anything, or any questions do you have or comments? Okay, good. Regarding eventration of the diaphragm. Eventration of the diaphragm, as we said, there is a congenital condition that results in lack of muscle of the diaphragm at parts of the diaphragm. This part becomes thin membranous sheet and it will be weak, so it will be elevated, okay? And it can involve just part of the hemidiaphragm or the whole hemidiaphragm. If it involves part of the diaphragm, this indicates it will be a smooth hump, okay? There will be a smooth hump. For example, in this picture, you can see a localized smooth hump at the right hemidiaphragm, which indicates a diaphragmatic eventuration. Now, let's talk a little bit about chest wall abnormality. First of all, do you have any questions or comments? Is everything okay with you? Do you understand everything, or is there anything not well understood? Okay. So regarding the chest wall abnormality, first of all, we have to look for the bones of the chest. So what are the bones that we need to look for or to detect abnormalities in them? First of all, check the clavicles. Old healed fractures are common in the clavicle because it's one of the bones that are frequently fractured, and they heal most of the times beautifully and easily with good alignment. So you might see evidence of big callus. This indicates old healed fractures. Erosions of the clavicle, they have a long differential diagnosis depending on the location of the erosions. So if the erosions of the outer end of the clavicle, this can be associated with rheumatoid arthritis, keep that in mind, and hyperparathyroidism. So the commonest causes of erosion of the outer third of the clavicles include rheumatoid arthritis and hyperparathyroidism. If you see hypoplastic clavicles, small clavicles, or agenesis of the clavicle, uni or bilateral, they might be seen with what's called Holt-Aram syndrome, also in cleidocranial dysostosis. Of course, these are congenital syndromes, so you will see these abnormalities in pediatric age groups, mainly infants. You don't expect to see Holt-Aram syndrome or cleidocranial dysostosis in an adult. Most of the time it will be in pediatric age group or infants. Okay? For example, you can see here, what do you see? What is the main finding here? We have hypoplasia or hypoplastic left clavicle compared to the right side, and this is a case of Holt-Aram syndrome. Now, what about this image here? You can see erosion of the outer third of the clavicle. The outer part of the clavicle is eroded. Also, the adjacent acromial process and possibly part of the scapula shows some erosion, and this was a case of rheumatoid arthritis. So these are the causes of erosions of the outer part of the clavicle. Regarding the sternum, of course we see it more clearly on a lateral chest x-ray rather than PA chest x-ray. So sternal fractures are most commonly due to steering wheel injury. The steering wheel in a car, when it's pressed against the chest, it might cause sternal fracture. So keep in mind that if there was evidence of sternal fracture in a road traffic accident, in a car accident, the patient is most likely is the driver who made the accident, because you need to have a steering wheel in order to fracture the sternum. Also, abnormalities of the sternum can be seen in congenital heart disease, for example, sternal agenesis or premature obliteration of the ossification centers of the sternum, and pigeon chest. These are abnormalities that can be seen in patients with VSD, ventricular septal defect. You might see sternal agenesis, premature obliteration of the ossification centers of the sternum, and pigeon chest. Okay? And pigeon chest is the opposite of pectus excavatum. Pigeon chest is when the sternum is bulging anteriorly, just like a pigeon. The depressed sternum, which is pectus excavatum, usually have an association with atrial septal defect, ASD, and Marfan syndrome. So you might see pectus excavatum without any other abnormality, just in form of pectus excavatum, and we talked about it in the previous sessions, that will cause displacement of the heart to the left side, and you might not see the right side of the heart or the right border of the heart, and this might be associated with atrial septal defects and Marfan syndrome. Opposite to premature closure of the ossification centers is delayed epiphyseal fusion of the sternum, and it is a feature of cretinism. So what's cretinism? Does anybody know or can give me the answer of what is cretinism? Cretinism is congenital hypothyroidism. Okay, congenital hypothyroidism, that is cretinism. Also, double ossification centers in the mammarium. Usually in the mammarium, in the pediatric age group, we have a single ossification center in the mammarium, the upper part of the sternum. Okay, if you see double ossification centers, two ossification centers, this might indicate Down syndrome, trisomy 21. Regarding the rib notching, the ribs usually, normally they don't have any notches at their inferior or superior borders. They are smooth. If you see rib notching, just like here and here and here, then we have a differential diagnosis for that. First of all, it might affect the upper, the superior border, or the inferior border of the rib. And each one has its own differential diagnosis. We have to memorize that, and you have to know what's the differential diagnosis for upper border rib notching and lower border rib notching. Also, it can be unilateral or bilateral. So let's start with the superior rib notching. What are the causes of superior rib notching? Which is all of these causes are not common. Most commonly we see inferior rib notching, much more common than we see superior rib notching. So the causes of superior rib notching include rheumatoid arthritis, SLE, hyperparathyroidism, Marfan syndrome, neurofibromatosis, and in patients who are paraplegic and polio patients. Okay, of course we have very few polio patients nowadays, but we have to keep it in mind. These are causes of superior rib notching. What are the causes of inferior rib notching? Like here, we have inferior rib notching here and here and here. Usually as a result of hypertrophy of the intercostal vessels. Okay, what is the most common cause of hypertrophy of intercostal vessels, intercostal arteries? The most common cause is what? Good. It's correctation of the aorta. Correctation of the aorta. Okay. Also, we might see rib notching, inferior rib notching in cases of neurogenic tumors. Before we go to the next slide, correctation of the aorta has two main types, either preductal or postductal. Okay, so which one is the cause of inferior rib notching? Preductal causes inferior rib notching more, or postductal? Do you have any idea? Let's wait for some answers. Preductal or postductal causes rib notching? Oh, a lot of you are writing. Several people are typing. Let's wait for the answers. Whoa. Pre or post? Okay, I will not give you the answer of that till I have some answers. Preductal or postductal? We'll go back to this slide later. Let's talk about cervical rib. What's a cervical rib? Cervical rib in humans is a supernumerary rib. It's an extra rib. Rib ziyada, extra. Okay? That arises from the 7th cervical vertebra. For example, here you can see this is the 7th vertebra, the C7, and there is a rib arising from it. Okay, and this cervical rib might be complete rib fusing with the clavicle, or might be incomplete, or it might be at the beginning bony part and continues later as a fibrous band, or it might be totally fibrous band. Okay, totally a fibrous band, and it might cause compression of the subclavian vessels between the extra rib and the first rib. Okay, also congenital rib anomalies such as hypoplasia, bridging, and bifid ribs are common, and we might see them a lot, and most of them in fact they are asymptomatic and just diagnosed accidentally. So what is the answer of this question? Is it pre or post ductal correctation? Again, And of course, the answer is post-ductal coarctation. That means that the coarctation is after the anatomical location of the ductus arteriosus. The ductus arteriosus, if the coarctation is after it, then we will have an inferior rib notching, okay? But if it is pre-ductal, it is unlikely to cause rib notching. So, what are the other causes of inferior rib notching? We have a lot of causes. You can see them here. For example, Blalock toothing operation, subclavian artery occlusion, or aortic coarctation involving the left subclavian artery or anomalous right subclavian artery. These are the causes of unilateral, while bilateral inferior rib notching can be due to aortic coarctation, occlusions, aortitis, subclavian causes involve the subclavian artery, including Takayasu disease and atheroma. Also, pulmonary oligemia, like Fallot's tetralogy, pulmonary atresia, stenosis, venous causes like SVC obstruction and IVC obstruction, shunts like intercostal pulmonary fistula, pulmonary intercostal arteriovenous fistula, and other causes like hyperparathyroidism and neurogenic tumors, and it might be idiopathic. Of course, we have a very good note from one of our residents that the postductal coarctation causes inferior rib notching that does not or spare the first two ribs due to the different drainage of the vessels from the first two ribs. So it will start, the inferior rib notching will start from the third rib and downward, okay? So, regarding rib fractures, there is something called cuff fractures, when somebody cuffs so hard with already osteoporotic or osteopenic bones. There will be it might be the cause of a rib fracture, usually involving the 6th to 9th ribs, okay? 6th to 9th ribs are the most commonly injured ribs in cuff fractures, while stress fractures that usually affects the first ribs. Pathological fractures may be due to, it's pathological, so the bone is abnormal, can be due to senile osteoporosis, old age, myeloma, Cushing disease that causes osteoporosis resulting in fractures, other endocrine disorders, steroid therapy, and diffuse bone metastasis. It's a very common cause of pathological fracture. Regarding Cushing disease, it is when there is Cushing disease and there is a pathological fracture, it will heal, but with a large or abundant or a lot of callus formation. The callus will be disproportionate to the size of the fracture or to the number of the fractures. Regarding the thoracic spine, we also need to comment on the bone evaluation. We should check for abnormal curvature, abnormal alignment, the bone and disc for destruction, sclerosis, also paravertebral soft tissue masses, congenital lesions like butterfly vertebrae, for example. If we see anterior erosions of the vertebral body, we need to look for the disc space. When you see anterior erosion, if the vertebra is eroded anteriorly, look for the disc. If the disc space is spared, it's not involved, only the vertebra, think of aneurysm of the descending aorta, yani abdominal aortic aneurysm or descending thoracic aortic aneurysm, okay? Also, think of vascular tumors and neurofibromatosis. If you see the disc space is eroded or is involved, then think of infective causes and abscesses and bacterial, like for example TB of the vertebrae. Single dense vertebra, what's called ivory vertebra. You see one vertebra that is so white, dense. This is called ivory vertebra. It's a classical appearance of lymphoma. Also can be seen in Paget disease and sclerotic bone metastasis. Most commonly, it will be prostate carcinoma. Okay? For example, what do you see here? You can see evidence of scoliosis, convex to the right side of the dorsal vertebrae, and there is evidence of some sort of surgery done for this patient. And you need, of course, to evaluate the lateral chest X-ray for further evaluation of whether there is any segmentation or fusion abnormalities. Destruction of a pedicle. If you see the pedicle destructed, whether in the thoracic, dorsal, or lumbar or cervical spine, the pedicle, if it is destructed, it is very, very typical for metastasis. Destruction of a pedicle, if you see the pedicle as loosened, not dense, this indicates metastasis. While destruction of a disc with adjacent bony involvement, the bone is abnormal, the disc space is abnormal. This is, as we said, characteristic of an infective process like TB or pyogenic abscess. Disc calcification, if you see the disc space calcified, the disc space should be loosened. If it appears white or dense or calcified, this is seen in what's called achondrosis and also in ankylosing spondylitis. So every pathology has its own differential diagnosis. Of course, the common ones are important. Now, after we check the bones, let's move to the soft tissues, the chest wall muscles and the subcutaneous tissues. Skin lesions can cause some densities on the chest X-ray, like nevi, lipomas, may simulate lung tumors. You need to take like at least two views, and you may need to take some tangential views to confirm that these lesions are in the skin, they are not in the lung. Okay, in cases if you cannot confirm, then you need a CT scan to confirm the location and the exact nature of this lesion. For example, a lipoma, you expect it to be less dense than the soft tissue. Multiple nodules, like here in this case, you can see there are multiple skin nodules everywhere. They are very characteristic of a neurofibromatosis, and of course you can see them by naked eye. You just look for the chest of the patient or the face of the patient and you see innumerable skin nodules. Mastectomy, it's one of the commonest causes of translucent hemithorax, as we said previously, and in case of mastectomy you will see no breast shadow and no axillary fold. There is something called Poland's syndrome. Poland syndrome, it's congenital absence of the pectoralis major and minor. So the pectoralis muscle, the pectoralis major and pectoralis minor will be absent. It will not congenitally absent, and this will result in increased translucency and unilaterally hypertranslucent hemithorax. It's associated with syndactyly and with rib abnormalities. Syndactyly means fusion of the fingers of the patient. So whether it is the hand or the toes, fingers or toes can be fused in cases of Poland syndrome. Also, you might see some rib abnormalities. However, most of the cases are asymptomatic. They are not complaining of anything because the rest of the muscles will take over and will help the patient to compensate for the hypoplastic or agenetic pectoralis muscles. Thank you very much. I hope you had a good time with this presentation on the chest X-ray, and we'll see you again after a few days with some other topic. Thank you very much.